I need to focus while knowing my patients will get the best care experience possible, whether they live down the road or in a different time zone. Something that delivers an experience and connection that helps us hold on to why we do what we do. Introducing ASC Solutions from Zimmer Biomet. Results you can measure. A partnership you can trust. As your trusted partner, we provide the tools to manage the pain points in your practice with solutions that drive profitability and support coordination and communication in the ASC. We offer products, services, and technologies spanning across the musculoskeletal space and continuum of care. Whether you're looking to open a new facility, add a service line, or enhance efficiencies, we have options to help address the most common challenges you face in an ASC. With our management services offering, we can help expand your practice or provide resources to help you get up and running, benefiting you, your staff, and your patients. Our Accelero Clinical Consulting Services are a team of specialists helping define the best outpatient joint replacement program for you, ensuring effectiveness across the entire episode of care. On the medical education side, we provide an interactive learning environment for advancing education and training with the goal of improved clinical outcomes. We also offer a comprehensive direct-to-patient marketing program to help drive more patients to your ASC. Our financial solutions are designed to empower you with the latest technology to advance care. And we are so confident in our offerings that we've included warranties on some of our products, including our Oxford Partial Knee System, Bactissure Wound Lavage, and Biomed Bone Cementar. Our risk share customer guarantee is a benefit of My Mobility and Accelero. Our care optimization offerings, such as My Mobility with Apple Watch, improve care coordination at every step in the episode of care. And our Efficient Care program offers streamlined surgical trays that have the potential of reducing costs for your facility. Our intraoperative robotic and guidance technologies enhance outcomes while staying efficient. And our surgical suite of technologies allows you to easily outfit your ASC with one vendor for surgical capital equipment and disposables. At Zimmer Biomet, we are actively committed to providing each surgeon the ability to tailor treatments for their patients' unique anatomies and conditions. The patient recovery process starts as soon as surgery ends, and our post-operative technology helps your care staff and improves the patient experience. We offer simplified billing through our One Bill program to increase transparency and reduce the complexities of multiple bills for a single procedure. Zimmer Biomet ASC Solutions. Results you can measure. A partnership you can trust.
Hello, everyone. My name's Sharon Edwards, and I am the ASC Medical Education Manager at Zimmer Biomet. I want to welcome you into our program this evening. We're glad that you're here to learn about digital engagement tools and why they should matter in your practice. For those of you who are joining us tonight via your private computers, we encourage you to use the Q&A button in the bottom of your screen to send in questions anytime throughout the presentation. And for those of you who are joining us who are in a group setting tonight, we've added a telephone number on the bottom of the slides, and we encourage you to text in your questions as well. We have a Q&A portion at the end of the presentation, and we'll address all those questions at that time. Zimmer Biomet is known as a proven leader in implants and orthopedics, and we recognize over this past year especially that the site of care for orthopedics is changing, and you as a provider are having needs that are changing as well. It's for this reason we've extended our ecosystem beyond just the implants to support you with such things as outfitting your OR, helping to optimize your patient care, and then in helping you to have your ORs to run very smoothly. And tonight, we're going to talk about one of those engagement tools, My Mobility, and here to help us do that is Dr. James Ballard from the Oregon Surgical Institute in Portland, Oregon, and also joining us is Tamara who is the VP of Global Market Access from Zimmer Biomet. So welcome to both of you this evening.
Thanks, Sharon. Great to be here.
Dr. Ballard, why don't you go ahead and kick us off this evening and talk to us about the digital tools that you've implemented in your practice and why they've made a difference and how they've made a difference not only for you but for your staff.
Yeah, well, first of all, it's great to meet with everybody. I'm out here in the Pacific time zone, so you guys got me out of clinic an hour early, so I'm always grateful for that. So this will be a fun hour. It's a really timely topic. You know, with COVID and all we've been through as surgeons, I live in a pretty restricted state from a hospital standpoint. So the move to the ASC world has changed, right? It's gone from being, 7 or 8 years ago when I started doing this out here in the Northwest. To be honest, it was just kind of a fringe idea that people thought was kind of interesting, and they kind of pat me on the head and be interested in what we were doing, but it hadn't really caught on. And we were fortunate to be ahead of it, and so that when we started getting shut down, that we could keep our practices going. And it's to the point now where the majority of all of my primaries, Medicare included, are now done in the outpatient setting. We built a facility in Oregon. It's not big. It's 3 ORs. We're expanding to 5. We've been fortunate to grow our volume to we're doing about 110 joints a month now. Of course, 110 is only not good because I wish it was 150. So we'll keep building. When we did this, like most of us and most of you that have either have made this move or are thinking about the move, it made us anxious because it was a completely different venue to take care of patients, and we knew we wouldn't have as close of an eye on people in that immediate 24 to 48 hour period. We knew we had to keep a tight eye on people, give them immediate access to this. So from the very beginning, we started our program with an online engagement tool that I've now transitioned into My Mobility. So to me, the ASC migration for totals and online engagement tool technology come hand in hand because leveraging technology, we leverage technology in every area of our lives. And the time has really arrived, I think, when we can't afford to not leverage technology as we, all get busy in practice and participate in this migration you see in this slide. And we've all felt it. I think we all sense the urgency of it. The growth in the outpatient space is positive in every portion of orthopedics, certainly total joints is high among all of those for all of the reasons that we all recognize. And the inpatient growth is declining. The good news about that is that migration has been great for me personally and professionally, but it's been great for my patients as well. We're not the only center to experience this, but the decline in complication rates and the improvement in patient experience has been dramatic. When CMS got on board with this idea and released their reimbursement for the site fee, it made a lot of people pretty nervous because, that number for Medicare reimbursement is not very high. especially when you compare it to commercial reimbursement in the ASC. The good news is that when we started, and I think we're not unique in this, we set up a model. We used the Accelerable consulting arm from Zimmer to set up a model to help us set a foundation so that we could control cost. So we were really driven towards efficiency to make cases like a total knee or a total hip on a Medicare patient be some of our most profitable cases in the ASC, in spite of what that number is. So, but there's no question that for all of us, patient care and quality of care trumps every other concern. And of course, the good news is, in an outpatient world, we can do all of these things together. We can improve our professional satisfaction, improve our professional footprint, but do it vis-a-vis excellent patient care. And so providing that care in an outpatient setting can be a bit challenging, especially when you're used to the idea of somebody being in the hospital for a day and a half and having nurses around them a lot, et cetera. So it's interesting that when you think about, I started into this business in my residency in the mid to late 90s. We haven't changed the MO really of how we handle things. I mean, we're still kind of, telephones, and if you're lucky, you've got a booklet for your total hip and total knee patients that tells them what to expect, and we still use kind of 1970s methodology to keep track of people, and yet all of us in our lives have these things, and these have revolutionized the way you go on vacation, the way you order food, the way you communicate with people in general. I text people. I probably text people 100 to 1 to phone calling, and we all know why, because that's just a more efficient communication. We can get more done with more certainty that way. So the time has definitely arrived for digital health changes and leveraging technology to improve our patient practice. The problem, of course, before MyMobility was where to find it. And Zimmer invested a lot early on. I mean, this is years ago, in developing this platform. And since its inception, when MyMobility came out, it was a lot like iPhone 1, and we're at about iPhone 8 right now. So things continue to morph and change, and what they're coming up with and what is down the road is super exciting. So MyMobility is, as this says in this slide, is a comprehensive care management platform. So it improves and increases patient engagement in their care. It improves patient compliance with their care. It is an efficiency machine. I know a lot of people start looking at this and go, "Oh, I want to add this work to what I do." And the reality is that MyMobility makes my office run better. It makes my staff, the care providers that work with me, my nurse and my nurses and my physician assistant, it makes them more efficient. It makes them better at what they do, and it makes them happier with their jobs. And then MyMobility is a data collection monster. I mean, it facilitates data collection, and it gives us a platform finally to do something with the data we collect. And the other thing is, a lot of what happens through MyMobility, as I talked earlier about leveraging technology, it automates a lot of this, not all of it. There's a lot of this interaction and engagement with patients that's automated, so that it's happening while you're doing something else. It's happening while your staff is doing something else. But patients, in spite of that, are feeling more connected to our offices, even with these automated processes. So if you think about what we've done traditionally and the amount of work that has to get done before a patient comes to the OR to get a total joint, there's a ton of stuff that has to happen. Now, to be honest, when I started back in the 90s, we kind of threw people in the water and hoped they could swim, right? That's the day before any kind of education class or preoperative optimization. But if you do it now, I think what we'd all consider the standard, you have this initial visit where you get consent, you educate people on the process, and you move into some kind of an education class. You have to set expectations with the patient. You kind of give them a roadmap. You go over all their medications. You kind of give them reminders. We've all had the patient that comes in and answers the MPO question, whether I had coffee and cream an hour ago because nobody told me I had to be NPO. You've all experienced that. And if you're going to assure that they're sticking with that, you got to put somebody on reminding them. And then, of course, the pre-op phone calls reinforcing education, all this stuff that we have to do takes time. It takes a human to do this stuff. And if it's not you, it's somebody else. And if it's somebody else, either you or your hospital is paying for that person. Then, of course, there's the education around the perioperative time period when they're about to go home. And then when they go home, then you got to have phone calls and follow up and checking in on their pain and how do you manage problems. And frankly, the way that we manage problems now, meaning in a pre-mind mobility world, is we're reactive, right? Somebody calls with a pain crisis. We react to the crisis. Somebody calls with a wound problem and they haven't been able to go get a hold of the office, and it's Friday at 3, and now you're reacting to a draining wound. It's almost impossible without an online engagement tool to get into a proactive patient management modality. But that's the way we need. That my mobility has helped me to move. So you look at the complexity of what's on the left and the simplicity of what's on the right. And the idea is your smartphone, whether it's an iPhone or an Android-based phone, radically simplifies most of your life. And if I came around and took your phone, we'd all feel helpless without our phones, right? So the time to bring that simplicity and that elegance and that efficiency into our practices is finally here with a system that has been very thoughtfully crafted, very well worked out. It is agnostic as far as implants you put in. You don't have to use Zimmer implants when you use My Mobility. And it is now available on this comprehensive platform. So there's a lot we can do with this platform, from education, virtual physical therapy, which we're not the first group to talk about virtual PT, but we've proven that it works. We'll talk about that. We've got the ability to manage patient biometric data in a way that lets us keep an eye on people and start to manage them when they run into problems before they become emergencies or catastrophes. We can get pain management alerts, range of motion alerts, physiologic data tracking, which I spoke about. We can bring messaging into the world of patient communication, which if you have ever been a patient yourself, or if anybody you love has been a patient and had to deal with calling a surgeon's office, it's worse than it sounds. It's just hard. So bringing text messaging and data and this modality into communication is a must. All of us struggle with problem collection. If you've got iPads or data sheets or whatever, you've got your nurse trying to figure it out. My Mobility, as we'll talk about, facilitates and automates the collection of problem scores. So you really don't have to do much to accomplish it. And then there's a strong telemedicine component to it as well. So when we talk about this comprehensive platform, we start with preoperative education. So if you're like me, at some point in your career, you've come up with a super cool binder to give your total hip and total knee patients that's beautiful and indexed, and it's in this cool 3-ring binder. Most people don't read all of that, and they certainly don't have it handy to reference when they're having a problem. We have finally now been able to use these smart devices to educate people, to engage them through push notifications. So instead of handing that big binder, My Mobility, through a configuration that you can either set up yourself individually or use a preset program, will alert people to the things they need to know as they need to know them. So what they need to know at week 2, they don't find out about it until week 2 shows up. And we all know, for example, that total knees start to be painful at day 2 or 3, and so they get a message on day 2 or 3 that says, "Hey, I bet you're painful," and gives them suggestions on how to handle it. So that idea of educating people with the phone works beautifully. And the concern about Medicare patients, my parents are in their late 80s and they can text, and we haven't had any problem with this with older people. As long as they can text, they can use this. So surveys, that's problem scores, check-ins where the program proactively queries them on how they're doing, and will take that information and alert the care provider team that something is happening that needs to be evaluated. And also, of course, the messaging program through text messaging. The physiologic and metric data that the Apple Watch program and the phone monitor and take care of has been highly valuable. When somebody calls into the office with a pain complaint 3 weeks after a total knee, finally I can look at something that tells me what my patient is really doing when they're at home. Because instead of hearing from the patient, they call and say their knee's killing them. You go, well, what have you been doing? And they tell you nothing. And then you go, well, that's weird because you've been walking 12,000 steps a day and they don't consider that was worth telling you about. I can manage pain totally differently now because I can look into what they're doing, what their heart rate is, what they've been up to before I just start talking about medication management. Video-based exercises where people can do therapy virtually. As I said before, that's already been proven to work by other studies. This just happens to be a very elegant platform. It's included in My Mobility. And when we studied this in a prospective randomized trial, 85% of people did as well with this virtual therapy modality as they did with an in-person therapist, which is huge, especially when we're in the world of post-acute cost containment. None of us like telemedicine. I don't think any of you liked telemedicine during the pandemic. I didn't. I still don't really like it, to be honest, but there is an Apple-level telemedicine platform with My Mobility. It's elegant. It works beautifully. For my patients that live at distance, which is quite a few of them, it allows them to check in with me without having to come into the office. And then finally, there's something that ties all of this together. So you can see in this continuum, there's a deep data collection that happens pre-op prom scores, post-op prom scores, data on gait, on how fast they walk, stair climbing, etc., data on their pain and all those things. Now, through the ZB Edge platform, Zimmer's actually doing something with the data. I mean, it's one thing to collect data. It's another thing to take the data and synthesize it, make it easily accessible, easily to digest, and clinically relevant. So that's the direction that ZB Edge is moving with this My Mobility platform. We'll talk about that a bit towards the end. So, the typical patient journey, right? They go home. Immediately the program begins to interact with them through their phone. They get a daily task chart that's both education, sometimes it's surveys, sometimes it's pain questions. It certainly is exercise routines. It's easily interactive. They get their stats. We get their stats on the online platform so we can keep track of it. If we need to, of course, there's the telemedicine check-ins. And it allows us to stay, frankly, so going back to my ASC experience, so my people are in my ASC for about 4 hours, right? From getting into PACU to going home. And yet with My Mobility and this online engagement tool, they are more engaged with my office than they ever were when I operated in the hospital. And the beauty of that is a lot of it's automated, and the clear majority of it is done by really great providers that work with me, my nurse and my physician assistant. So this is a video that's going to go through a simulation of an experience with My Mobility, both from the side of a patient and second from the side of a physician. So I'm going to hopefully play this and see if it works. It is working. Okay, great. So what we're going to start with is the patient logging in. My screen is really small for this. This is really testing my new glasses. So this is going to be their daily task that they're going to get. The top is going to be their education, I believe, because this is such a small screen for me. And they're going to get different messages at different times of the day. And then they're going to get exercises as well. So if there's anybody from Zimmer on this is so small I can't really see it, so I apologize for that. I just know what comes next. I think I know what comes
Dr.
next.
Ballard, this is Sharon.
Yeah.
You can adjust your screen. If you just go into the black lines in between, you can pull that down and make your screen come bigger.
You think so? There we go. Okay. Thank you, Sharon. Okay, so this is where it's monitoring the patient's pain. That was a Coos score. And you can see that when that's completed, the pink goes away and the check mark comes in its place. This is going to be the physical therapy routines. Of course, they can't go to the PM ones because they haven't done the morning one. So they just click on it. There's a video that shows an example of the exercise. When they're done, they enter how many reps they're able to do. Then they move on to the next one. So what we're going to do is just kind of walk through and go, and then you just go one to the other. And there's excellent video examples of what they're supposed to do. If they can't do all 10, which is a suggestion, then they put in less than 10. This is one that's we're going to actually look at the video now. And this is what the demo would look like to the patient. You can see they're just using an empty soda bottle under the foot, so it's pretty easy to set up. And this guy demonstrates it, then the patient just goes and does it on their own. And I'll tell you, not every patient loves it, but the clear majority of people do very well with it. And it's been a huge thing for patients because it's cheaper for them because they don't have to go home and pay for therapy. So when their morning routine is done, and ask them to rank how hard it was. So if they had a hard or an easy time, they can tell us. In this example, it's going to tell us that it was kind of hard. That's going to later trigger a note to me about that. So now you can see that that's all accomplished. They now have a daily walking goal to keep up with. They can see on their upcoming calendar, they've got an e-visit with the physician. It gets them ready with their microphone and with their camera, kind of setting that up. It'll then set a note in their calendar to remind them, and the phone will notify them that they've got a visit if, in fact, they're doing a telemedicine visit with their doc. And then there's a pain rating section where they go in and now rate their pain. It kind of walks them through like what we're talking about with the rating. Now, I'm not a giant fan of the 0 through 10 scale, but it is a way to give us an idea of where people are going. It asks the questions that you would ask, like, now, how is it? What medicines are you taking? Are you taking more or less narcotics? Are you using non-narcotic medicines? When do you hurt? Where does it hurt? What starts the pain? So that when you get this message, which My Mobility will give you the message that, Mr. Cooper is having knee pain, before you talk to them, all these questions will already be asked and answered. So you'll already know that they are or aren't taking, non-narcotic, over-the-counter medicines, etc. So it gives you some information prior to calling them. And then it'll give them some ideas while they're waiting to hear back from you about what they can do. It shows their progress, both with how well they're doing with their education, their surveys, and how well they're doing their exercises, and how compliant they are with wearing their watch, if in fact watch is part of their program, which it doesn't have to be. So now we're going to go to the doctor side. So now the doctor logs in. This is what's called the dashboard. When you log in, it'll have all of your patients on here to start. At the top, there's a thing called an exception. That's the thing that this program's alerting you to take a look at. These are patients that you can sort them by people that haven't had surgery yet, people that are post-op, people that are post-op more than 30 days. You can do knees, you can do hips. So the exception is the program saying, look, this guy needs you to look at him. There's something about him. So you click on his chart. It opens up and gives you the information. How well are his exercises going? Is he doing his education? What's his step count like? This guy's step count was at 11,000 in that example. What's his heart rate like? Heart rate variability. It gives you the background. And then you click on the exception, and the program will now tell you what was the problem it's alerting you to. And in this case, it's his pain. His pain rating is an 8. That's what we just went through. And now you can know proactively this guy's having, an 8 level of pain's a bit high. And now you can message him or interact with him the way that you want to. You can ignore it if you want, or you can message him or call him to get ahead of it. And from my experience, not everybody's saying 8 every time they have pain. So it works fairly well. These are alerts that you can send among care team members, where you can tell the program different things that you want to be made aware of. They come in yellow and that kind of red-pink color. Red or pink is more urgent than the yellow, but it'll tell you the number of flags. That button at the top right is the number of text messages that you have. So when it'll just list off the people that have sent a message that you need to get back to. In this case, this guy is just saying that, hey man, my exercises are a little tough. And it now lets you proactively go look at his chart. Like, well, let me look and see what he's doing. So you can go look at his progress, see what his biometric data is looking like. Because maybe he's doing too much, which happens, right? Maybe he's not doing enough. You can get an idea ahead of time before you respond or react to what he's telling you about his exercises. And there you can see that pain chart that went up there. So when you look at the protocol section, you can see the things that he's been reading or looking at. Now, this is a pretty granular dive. And to be honest, this level of granular dive is usually done by my nurse, by me occasionally, but usually by my nurse when she's trying to figure out, kind of sort out the problem. And in this case, you can see that he's not doing so hot with one of his exercises. what we can do now is we can go back to a message and say, look, in this case, we're going to we can send him back a more mellow exercise regimen, let him know that we're aware of what he's up to, and it makes the patient feel less anxious and responded to. And again, it's just one of those examples of how the program proactively can help us head off a problem. Here, if you wanted to, you can look at the breakdown of his Coos Junior score to see where he was doing well or not doing well. Connections is where we bring in data from Persona IQ or from ROSA, which we'll talk about in a second. The Persona IQ data has its own level of granularity. This is the early data that we're going to be harvesting from IQ, from step count to distance walk to cadence, stride length, etc. So you can go right from My Mobility into the imported IQ data, which is cool because it keeps it all on one easy to manage platform. Here's ROSA. So the left is the patient's pre-op deformity, the middle is how we corrected it, and the right is how we changed it. So you can actually go and say and wonder to yourself, man, what did I do to this person with ROSA, and find out how much of a correction you actually gave them during the surgery, which again, it brings the data from robotics into the management of the patient on a day-to-day basis, which has the potential to be super powerful. Now, I do hip and knee replacement. My Mobility covers a much broader spectrum of orthopedic procedures, of course, total shoulder. You can see the list here, foot and ankle, a lot of spine. The HSS thing on the right is a collaboration with HSS where their patient pathways for these things are going to be in the program, and you can just go right ahead and adopt what HSS does if you just want to go to what they do. It's kind of a powerful tool for somebody as well. So what has My Mobility accomplished so far? Well, first of all, there's been almost 2 million patient logins to the program to this point, and that, of course, grows every day. The clinical study that we started early on has 24 locations, and I think we have about 6,300 patients building towards 10,000. So we are in the middle of developing and running a 10,000 patient prospective study on the utilization of this tool, which is yielding even already significant data and insights into managing hip and knee replacement. We look at what we've accomplished so far with an online engagement tool like this. We've significantly reduced PT utilization, which again, in a world of cost containment is important. But again, we've done it without sacrificing quality for the patients. ED visits are dramatically lowered, of course, because patients are listened to. If you're a patient and you've got a concern and you can't get through to somebody, to manage your own anxiety, people typically go to the ED or to an urgent care, and utilizing an online tool lowers that, and we've shown that in this study. As far as the quality of the experience goes, just like, hey, how much do you like the experience? In the study, 80% of patients rated the My Mobility, because we compared My Mobility versus standard care. 80% of people rated it better or much better than what we were doing before in the pre-My Mobility paradigm, and 63% of patients said it had a better or much better impact on lowering their anxiety. And again, if you've ever been a patient, management anxiety is really important. And you guys all know that for hip and knee, that managing anxiety can play a really significant role in improving outcomes. So that's significant. The physical therapy piece is important because when we compared the group that had virtual PT versus standard PT, we had no difference in 90-day range of motion and no significant increase in total knees with manipulation requirement for manipulation under anesthesia. And we're not the first group to show that, but it definitely highlights what we've known from before. So My Mobility in an ASC setting has opened the doors for us, an online engagement platform to prepare patients with less human hours, but with more effectiveness. It's an efficiency machine in the office for keeping track of people, good quality track of people. It maximizes what we can do in the center, because to keep track of all of these people takes a lot of people unless, again, you leverage technology. And we would never be at the 1,000+ per year joint mark at our center without an online engagement tool. And the platform is scalable. You can go from as few to as many patients as you need. So I'm going to kind of wrap this up talking about intraoperative technology briefly. Persona IQ, many of you have probably heard of this. The world's first and only smart implant. It's right now available only in total knee. I'm just going to give a 30,000 foot view of this. It is an incredible sensor that takes the place of what we would call in the persona the stubby stem. It's a bit longer than the stubby stem. It has a pacemaker battery in it. The pacemaker battery was chosen because it's got an incredible track record with implanted human safety. So that's the battery they chose. It has an incredible collection of sensors that's going to collect incredible data from motion to vibration to temperature and start to unlock insights into total knee we've never had before. The way it works is the implant samples motion throughout the day. Then when you go to bed at night, there's a Wi-Fi connected platform underneath your bed. It looks like a squished modem kind of. And while you're sleeping, it downloads to the modem, which goes up to the cloud. And that data is imported into the My Mobility dashboard, making it instantly available to a clinician to keep this careful track of people in a different way than we've never had prior to this. Right now, again, I would compare IQ to the iPhone in that iPhone 1 is nothing compared to what this one is, because as it's been in practice and evolved, so much has changed. With the iPhone, the beginnings of IQ are measuring speed, cadence, stride length, the things that you see mentioned there. And there's no doubt that as we learn more, because nobody's ever on a commercial level released an intelligent implant that will have this broad of an application, we just are going to learn a ton about what this thing tells us. And it's exciting to see what kind of predictability we will be able to use to help people through this recovery from what we all know is a super difficult operation to recover from. So the dashboard for IQ will look like this. And again, right now, this is what we're monitoring. Here's what's interesting about this. As we learn more, and as the really smart folks in charge of this decide, hey, we want to sample 3 additional things, what they can do is go to the program and change it. And the program will go to every base station and back to the very first IQ ever implanted, reharvest all of that data. So if in a year we change the sampling, it will apply to every IQ ever implanted, which makes it all the more powerful, because as we change and learn, we can retroactively apply it to all the needs we have implanted. Now, something that's really close to my heart is ROSA Robotics. I don't have time to give it a lot of justice. I was a deep robotic skeptic a couple of years ago. I've been quoted by Zimmer multiple times saying I would never put a robotically implanted knee in a human. and now I'm a huge advocate now that I've used it for a year and a half. ROSA is surgeon-centered, which just means you get to do a total knee the way you want to. If you're measure resector, or if you're a gap balancer, or if you're like a lot of us in a hybrid approach to a total knee, you can do this really however you want. You want to cut the femur first, the tibia first, whatever you want to do. Accuracy, I mean, it's robotic, so the accuracy is there just like other robotic systems are accurate. It can be very efficient in cutting down on the number of trays you have to open and decreasing the steps in an operation. To be honest, my time is neutral with my non-robotic knees, what I did before. And the key thing also is ROSA is data-driven. It collects data, other systems collect data, but the ROSA data is imported to My Mobility, and it's going to allow us now to see how what we do impacts patients. And the cool thing, actually, which I'm about to get to, is Zimmer is investing a lot in the post-collection management of the data. So you can say all day you collect data, great, but what happens because of the data collection? So Zimmer is leveraging this data to the point where we're developing now predictive analytics, using the data to find out what is the best approach to a certain type of arthritic deformity. Where should a patient be in the path of their recovery for their average age, sex, and deformity, etc. There's a lot of exciting stuff coming down the pike, and a lot of stuff that's going to be announced at Academy that's super exciting, and I was sworn to secrecy about, so I can't say it. But listen up at Academy; it's going to be super cool. This is the ROSA planning screen. So when I first saw this screen, my head exploded. I had no idea what I was looking at. I think I needed some Advil and a Tylenol because it just it was such a busy screen to me. Fortunately, I took the time to understand it, and to be honest, a year and a half later, this is my favorite part of the total knee. It's where all the power with ROSA is. They're really detailed soft tissue inputs we can give ROSA for gap management is just super, super powerful. This is the data that once I do a ROSA, This is uploaded in my mobility, and I can log into a person's chart and pull up the data. So the left column again is what was their deformity, what were their gaps. The middle is what did I do, and the right is what's the delta, how much did I change them. And this data is going to be leveraged, and it'll be very powerful as time goes on, as we start predicting what kind of operation is best for a certain deformity. So this is where we end off on with what's called the OrthoIntel Orthopedic Intelligence Platform. This is the ZB Edge. So all of the stuff that I'm talking about is underneath the moniker of ZB Edge. So this is the data management tool that sits above everything and ties everything together. So it uses personalized artificial intelligence, machine learning. It's adaptive, it's automated. It's something that creates reports that are usable and that take about 2 seconds. You don't need an IT person to figure it out. It's super simple to get these reports, and the quality and the depth of those reports is building. It's giving us insight into what we're doing. It's effortless from a user standpoint, and I can't say that we're automated enough because it doesn't require much for me to create it. That's the typical My Mobility dashboard, and this is the OrthoIntel dashboard that we have right now. So what I can do now with my total knees is compare them through a variety of filters. My ROSA versus my non-ROSA patients, my patients against the My Mobility universe, against the thousands of people that have been operated on in here. I can compare multiple biometric measurements to see how they're doing. In this particular one, we're comparing steps. So that the green is my patients, the blue is the network. Of course, I picked this because mine were temporarily doing better, which I'm not sure it's that way in every category, but here it was. But you can start to really filter this out and even begin to use this to help people benchmark where they are. People really hunger for benchmarking, and we're going to be able to now go, listen, let's look and see how you're doing compared to everybody else in this My Mobility universe that's your age and your sex and that had your surgery. And that benchmarking will be super powerful. So the cool thing to wrap this up and now to hand this off now, Tamara, is that we're finally, the world's changed. We all know that. COVID, remote, telemedicine, monitoring people remotely. We've never had the ability in orthopedics to really, truly, effectively monitor people remotely in a way that was meaningful, not gimmicky, not just something, we're just going to do this so we can bill for it. And what's cool is it's real and it's going to grow. And we're at a point now where CMS is recognizing this. And through remote therapeutic monitoring, we can now begin to bill for this for a meaningful service that means something to patients and have it be something that we're reimbursed for. And Tamara, who knows a lot more about this than me, and frankly, I'm going to sit and take notes because she's super smart, is going to tell us about that. So Tamara, why don't you take it away?
Thank you. Thank you, Dr. Ballard. So I wanted to go over some of the highlights of remote therapeutic monitoring because, as Dr. Ballard mentioned, this is new for orthopedics. Remote monitoring has been around for over 20 years in cardiac and for continuous glucose monitors. So it's not a new service, but it's new to us. The other thing that's new is the set of codes that we'll talk about tonight for remote therapeutic monitoring. These are new codes that were effective on January 1. So everything is hot off the press that we'll cover tonight. But this group of codes that I'll focus on tonight were designed for orthopedic and respiratory technologies. So knowing that the data that we're collecting is therapeutic in nature versus there's been a lot of talk about the remote physiologic monitoring codes or RPM. And all of the data that we collect is not necessarily physiologic in nature. So we'll focus on these RTM codes because they are specific to orthopedic procedures like My Mobility and like Persona IQ that Dr. Ballard highlighted. What I wanted to mention is one thing that we've done in advance of these codes being effective on January 1st is we registered My Mobility with the FDA as a medical device. There is a specific definition called software as a medical device, or SAMD. So My Mobility is now registered with the FDA as a medical device. And what that means is all of this great data that Dr. Ballard highlighted can be used in order to remotely monitor a patient, which is new and very exciting. But I wanted to make sure everyone is aware of that. There's a couple of things that I like to highlight about these new codes, and I'll move over to our coding sheet that everyone will have access to give you the exact codes that we're talking about. But the RTM services, as you think about it in your practice, this is a service that can be billed once every 30 days if it's appropriate for your patient. And it can be done either by you as the surgeon or by what Medicare calls a qualified healthcare professional. That's a PA, that's a nurse practitioner. Generally, based on your state and the scope of practice, a QHP has their own Medicare billing number, if you will. The RTM services can also be ordered by you as the surgeon and then provided by your clinical office staff. Medicare calls this incident to billing. So it is something that extends the ability for you and your practice to monitor patients in the best way that you see appropriate. A couple of the billing guidance that we'd like to highlight for your education is at least 20 minutes of monitoring must be completed on that 30-day or monthly period to meet the billing requirements. So if you're using My Mobility today, I've talked to a lot of surgeons and a lot of practices since the beginning of the year. This may be work that your practice is already doing. And I think Dr. Ballard mentioned that. So monitoring the patient, at least 20 minutes a month is the requirement for billing. And then lastly, there is one interactive communication with the patient that is also required. So that could be a phone call, it could be an email, it could be, a telemedicine visit, that's performed through My Mobility. It's really, the definition is very loose, if you will. That way the care can be delivered to your patient the best way that you see fit. So remember, at least 20 minutes a month. There has to be one interactive communication. And the other requirement that I'll mention that's in the code definition is the device, meaning the My Mobility software or the Persona IQ has to collect at least 16 days worth of data from the patient during the month. So those are some of the highlights. And I'll advance the slide forward and get to, hopefully everyone can see the codes here. I don't know if you can see my pointer here, but the remote therapeutic monitoring codes are on our coding sheet, which is available to everyone here. But what we like to do, and I want to walk you through a couple of these codes because everyone wants to know, what do I have to do? And then of course, what's the potential payment? So the first code that we're looking at here is 98975, if you can see that. Hopefully it's big enough. This is an education code. So this is billed once per episode, and it is a way to recover some of the time that your office staff will spend getting the patient set up with My Mobility. So the average Medicare payment's about $19, depending on where you are in the country. And then for the actual monitoring itself, there are two codes. The 98977 is what Medicare calls the device supply code. So there's two components of the remote monitoring session. The actual device supply, which is My Mobility, now that it is registered with the FDA as a medical device, that is paid on a monthly basis at $56 per month. And then the actual monitoring that I had mentioned earlier, that 20 minutes per month is paid at $50. So if you have a patient, maybe they're having a tough time or they're having some significant issues, And if that monitoring goes beyond the first 20 minutes, there is an add-on code, as we call in our reimbursement circles, for each additional 20 minutes. We're not really sure that the average remote monitoring sessions will take at least 40 minutes, but if they do, there is an add-on code to capture that additional time. That is $41. So basically, if the 20 minutes per month are provided, getting the device supply as well as the actual remote monitoring service, it's about $106 per month. And that one-time setup or education code can also be billed once per episode. But those are the codes, and like I said, everyone will have access to this coding sheet. I also like to mention, with these new remote therapeutic monitoring codes, there is no restriction on the global surgical period. The RPM codes that I mentioned earlier, they're in a different category of codes, and that global period, that 90-day global period applies. So what this means is, let's say right after surgery, if you want to start remotely monitoring your patient, you can certainly do so. We suggest that since this is a time-based code, however you document your E&M codes or your evaluation and management codes, that could be a similar process, since those are time-based and the remote monitoring codes are time-based as well. But that is a very high-level overview. What I also like to point out is some of the services that we have at Zimmer Biomet include a reimbursement hotline. And if you can see this, the print is really small on my screen. But we have an 800 number, and we have a website. We have an email address. So if you have specific questions, we're really happy to talk to you and your practice and make sure you have the education and the background if this is something that you're looking to implement in your practice. So that is what I've prepared for tonight. So I'll hand it back over to Dr. Ballard.
And I think that goes to you, Sharon.
It does go to me. Thank you so much, both Dr. Ballard and Tamara, for that great information on all the digital tools and the remote therapeutic monitoring. We do have questions coming in. I do want to just say one thing, that for those of you who, we know that coding was very, very small. That list, for those of you who are online, is over in the resource area just to the left bottom of your screen. That's downloadable if you want to click on that and download it. For those of you who are in a group setting, we are going to be sending that out as a follow-up to you tomorrow. So just wanted you to know that we understand it was very hard to read. It's a lot of information. So that'll be coming in to you very shortly. Also, just want to remind you, now is the time, if you have questions, to enter those questions to the Q&A box or send a text to that phone number that's on the screen, 574-310-0719. So, Dr. Ballard, we do have some questions coming in. I'll start with you because specifically about My Mobility and the Apple Watch. A question was, do you have to have an Apple Watch to be able to use My Mobility?
No, it's compatible with Android devices as well. The addition of the Apple Watch is just another level of service within the My Mobility platform. So you can do it with or without. And there are different ways to help people obtain the watch and deal with that. So it just depends on how you enter the program.
Okay. And Tamara, same question for you. Do they have to have the My Mobility Watch to do the remote monitoring?
They don't. They don't.
Okay. The next question was, can you assign exercises for My Mobility pre-surgery as well as post-surgery?
I've only done it post-surgery, so that's a great question. I have not done it pre-surgery. And to be honest, I don't know the answer to that.
Hi, Sharon. Molly's here. So you can assign exercises pre-surgery as well.
There we go. Thank you, Molly.
You're welcome.
Thank you,
Save
Molly.
the day.
Molly is from the product side of the My Mobility team, so we appreciate her jumping in and helping us with some of those questions this evening. Another question around the Ortho Intel portion now. The question is that an add-on software that you have to purchase additionally, or is that part of the My Mobility package?
So that's a great question, and the great answer is no. It all comes with the program. So just like telemedicine is on there, just like virtual physical therapy is on there, Who's and Coos Junior collection, Ortho Intel, all that reporting, creating the data sets and all that, it's all part of it. No additional software to purchase, which is great.
Okay, that is great. And then one more My Mobility question that I see here, and then we've got several for remote therapy, so I'm trying to just keep both of them going. The question is there a set of questions for prompts being collected, or can you make up your own prompts?
So Molly, I'm going to give my answer, then you're going to lay over the top of my answer. So the prompts that we're collecting standard prompts like Who's and Coos Junior that have standard questions. So people are getting queried, but they aren't in a prompts context. So when they're being asked questions about pain and location and all that, those are outside of a prompts collection, but ours are standard collections, standard measures that are common to the industry.
Molly, did you want to add on to that?
Yeah, just to echo what Dr. Ballard said there, we have procedure-specific prompts that cover the breadth and depth of orthopedic procedures available to be selected from, and then with some of our exceptions, such as the pain management exception, we will prompt the patient to answer questions around pain prevalence and specific activities related to pain.
Okay, great. And then I'm sorry, I had one more come in for My Mobility real quick. And I'm sorry, not sure I understand this question, but I'm going to read it. Can you communicate with patients? Can your communication with your patients be loaded into Epic? And I'm sorry, I don't know what Epic is. Does either of you?
I do. So I'll give the answer, and then Molly's going to bring the corporate right on top of it. So with the number of EMRs that we all use, for example, I use Centricity, which now has a different name. I don't use Epic in my office. There isn't a direct connection between My Mobility and my EMR. If I wanted to do that, which I leave it stored on My Mobility, if I wanted to, I could print it off and upload it like I do a fax from the hospital. But there isn't a direct connection now. Molly, do you want to chime in on that?
Dr. Ballard, you're absolutely correct. So as of right now, our customers would have the ability to print that exchange or print PDF and upload to their EMR. Integration with EMR is on our roadmap and something we look forward to being able to share with our customers in the future.
But I want to make a quick comment, Sharon, about what you said about roadmap. Most of the time you hear from an orthopedic company that tell you it's on their roadmap, every surgeon's going to laugh at this. It's like Q3 of 3 years from now, right? And it's their way of brushing you off. I'm just being honest. With My Mobility, and this has been true every time, when I've worked with the My Mobility folks over the years, and we've come up with things like what Molly just mentioned, and they tell you it's on their plate. It is, and it'll happen. There has not been a time yet when an idea has come up that they've agreed to work on that it hasn't happened. So in this situation, what she just said, you can bank on that. That will be happening.
Great. Okay, I'm going to switch gears now and go over to some questions about the remote therapeutic monitoring. One of the questions, does the My Mobility billing, does it commence during the first 90 days after surgery, or does it start after the 90 days after surgery?
So I want to answer this in two ways. So the billing is for the remote monitoring service. And if you think about it, all the data that's collected in My Mobility and even Persona IQ is great data, but Medicare and all of our payers here in the United States pay for services and procedures. So remember, we're billing for the remote monitoring session. All the data that's collected by My Mobility informs that remote monitoring session. But as I mentioned, with remote therapeutic monitoring, that 90-day surgical global period does not apply. So if the surgeon, let's say Dr. Ballard, implants a patient and wants to start remotely monitoring them the day after surgery, he has the ability to do that. Because with these new codes, they don't include that 90-day global period.
Okay, that's great. Especially, I can see where that can be very beneficial, especially
Yes.
have someone who has a lot of comorbidities to be able to monitor them right away. That's great. Another question: is there a limit on the reporting RTM services?
So today there is no limit on how frequently, or how long the remote monitoring services can be billed. But what we suggest is a very conservative approach that, based on the patient's medical necessity, that's how long the remote monitoring should happen. Since this is new in orthopedics, we don't know if it's 3 months, if it's 6 months, if it's 1 year. Obviously it's patient specific. But right now, there are no guidelines on how long the remote monitoring can be provided. That may change in the future, but there's no guidance today.
Okay. Then another question is, who can actually do the billing for the remote therapeutic monitoring? Who has to do that?
So the billing is either a physician, a surgeon, or what Medicare considers a qualified healthcare professional. And a qualified healthcare professional is a nurse practitioner, a PA, and like I mentioned, generally a mid-level provider, if you will, who has their own billing number with Medicare. But remember, the mid-levels are paid 85% of the Medicare allowable versus, physicians are paid at 100% of that Medicare allowable. But it may make sense to have, a qualified healthcare provider in your practice perform the monitoring just for, practice economics.
And I have one more question. So before I ask that, I just wanted to let everybody know, if you have a question, please get that in to me immediately so that we can answer it before we end the program. But so Tamara, the last question we have for you is, what services contribute to the required 20 minutes for RTM?
So that's a good question that we get a lot. So it includes reviewing your patient data that Dr. Ballard covered during the program. The time that is spent on reviewing the patient data, the interactive communication with the patient, like I mentioned, if that's a phone call, if that's an email, if that's a televisit, etc. Monitoring the patient's prescriptions, monitoring the patient's treatment or care plan. Those are all services that can account for the 20 minutes of monitoring per month.
Okay, and we had another question come in. Who will own the data for Persona IQ, the data that's in My Mobility? And do patients have to consent to being a research subject?
I'm going right to Molly on that one.
So it is my understanding that whoever purchases the product owns the data, and patients, as part of the onboarding, are consenting to allowing, Zimmer Biomet to utilize their data to improve the product.
There you go. Okay. Well, I just want to thank everybody for joining us tonight. This has been a great WebEx, lots of good information. We appreciate. We are sorry for the inconvenience of some of the difficulty in logging in. We are recording the session, so we will be sending some things out to you. Probably tomorrow. Sorry, just got another question that came in. We are multi-physician practice, 4 surgeons and 2 non-op sports meds. Does my mobility accommodate for these 2 sports med doctors? I'd like to track some different things. This would also allow us to show our conversation therapy.
Conservative therapy.
I'm sorry, conservative therapy.
I think it's a great idea. I love that desire to track both of those things because, as we know, Visco's got a little bit of a mixed reception amongst us. Molly, I don't ever do that. Can somebody do something like that? I don't even know.
So I apologize, but I'm not sure I fully understood the question. Like key communication between.
No. So what he's asking is, there are non-surgical treatment modalities for arthritis, injectables like your guys' Gel 1 or platelet-rich plasma. He wants to inject these and then use my mobility to query people to see how well they do, to follow their prom scores over time. See what I'm saying? To almost treat it like it's an operation.
So at this time, I don't believe we have any protocols that would allow for that. But it is a really interesting question. So it's something I will elevate to our development team and pass along that.
And I think that's Dr. Smith. I'm reading the name, or Stroth, sorry. See, the great thing about what Molly just said is that if you come up with a good idea, and it's a genuinely good idea, and it has broad application, they'll work on it. So that's the fun thing about this whole program is that it's going to build and grow even more than it has since I started with it, which is really exciting.
So, Dr. Ballard, just a clarifying question on that. Would those be pre-surgical patients?
Those would be people that are so far pre-surgical that they're not even tracking them in a surgical experience. It's an intervention. Yeah. You would call it an early intervention to hold off on the need for a total knee.
So I know we have
great question, but I don't think we have the answer to that.
Yeah. We'll have to follow up because I know there's been a lot of talk about tracking pre-surgical patients and my mobility. So
yeah, we'll see. Who knows where we'll go?
Yeah.
Okay. Well, again, thank you for everyone being online. I just wanted to let you know ASC Solutions is out and about in many places this year. So if you're interested in coming and joining us at a live event, you can go online at dbinetwork.com, and we have a full list of the calendar list that's there. You can register directly there for events. This is a quick look at lots of different locations that will be out, we have half-day regional meetings, we have state association meetings that we're at, and then these are all the industry events that we will be at this year. So come join us at a live meeting, meet Dr. Ballard in person if you like. Also wanted to let you know that we do have an educational website. It's called the CBI Network, and you can access that through the internet or now through your phone by downloading this app. That information, the information that you can get on there is you can see all the calendar of events and register directly from your phone. Or we also have lots of videos on there. This video will be on there soon that you'll be able to access with the app. So I encourage you to go to your app store or to Google Play and download the apps and stay educated with everything that Zimmer Biomet is up to. And of course, if you have any questions about anything that you heard tonight or any ways that we can help you in the ASC space, we're always here for you. ASC Solutions at ZimmerBiomet.com is our email address that comes directly to my desk. And I'll be happy to talk with you. If I don't know the answers for you, I'll find you the right people and get you in touch with people that can really help you. So again, thank you, Dr. Ballard. Thank you, Tamara, for joining us. Molly, thank you as well. And we hope you all have a great evening and come back and join us again soon.